So I'm gonna go ahead and get started, and probably towards the end we might skip some of this stuff. It's more of a gonna be FYI, but I'm just gonna talk a little bit today about the history of antibiotics and where we are right now, and why is the history important, because we're possibly heading to that same era as previously. So the objectives is basically to describe the timeline of discovery, understand the current trends, and discuss some of the implication of what is happening in the society overall today with their antibiotics. So I'm going to start off with the pre-antibiotic era. Anyone know what that is or a picture of?
Oh, is that bloodletting?
Yeah, so this is the barber surgeon, right? So before antibiotics existed, you would come to your barber, he would bleed you and give you a haircut at the same time, and yank your tooth out if needed. And those red and white things they see at the barber shops, right, that hang, that would be where the blood would be coming down and pooling at. So that's this is the pre-antibiotic era.
Don't worry about my barber still letting blood.
So pre-antibiotic era. So no surprise. In the early 1900s, the leading cause of death was pneumonia, tuberculosis, and diarrhea. So infectious causes, right? Things like strep pyogenes actually caused half of all post-birth deaths, right? This was called like women's or partum fever or women's fever, or they would have this problem. And then Staph aureus wound infections, take this for granted. Oh, you have MRSA, here's some Bactrim, and we're 80% fatal. So it really was a problem. All right, things that you're not going to see now because of antibiotics that we have. So 1865, look at that child with impetigo. Like, this is not something that you can even imagine now. And then orbital cellulitis with an abscess. So if you have no antibiotics, I mean, all you're doing is this is very so the antibiotic era, the golden age. And do we know who this guy is? Yeah, Alexander Fleming, right? So in 1928, Alexander Fleming basically accidentally discovered that something had contaminated his plates of Staphylococcus. He was actually actively looking for antimicrobials, and so he would go ahead and plate staph and put them in his incubators. He actually went on vacation and forgot to get rid of some of the plates, and ended up coming back, and so it was contaminated, and actually saw the clearing around. So accidentally actually discovered this. The problem was that they could not mass produce this, right? So it wasn't until 1939 that mass production of penicillin was actually something that we had. So really the first antibiotic that came into use was a synthetic or a man-made antibiotic. It was in 1936, and it was a sulfanilamide or a sulfa type antibiotic. All right, so this was really exciting, right? So now penicillin, could be given for things like gonorrhea, and soldiers were not dying from wound infections anymore, right? Or, so this was a big deal. It was really something that changed things. So this was termed the golden age, because if you look, you had about between this time 14 novel classes of antimicrobials that were developed. So not just different drugs, just 14 unique classes. Since then, we've really had maybe 4 total. That includes topicals as well. So not no wonder it was called the golden age. So of course, with all this development, everyone is super excited, right? So in 1967, the U.S. Surgeon General William Stewart was quoted saying, "The time has come to close the book on infectious diseases. We have basically wiped out infections in the United States." Really optimistic, right? And Dr. Robert Petersdorf, who was one of the top ID people, of his time, basically was quoted saying, 1978, "Even with my great personal loyalty to infectious diseases, I cannot conceive of the need for 309 more graduating trainees in infectious diseases unless they spend their time culturing each other." And then again, in 1985, which was not that long ago, at the IDSA meeting, or ID week now, quote, "The millennium where fellows in infectious diseases will culture one another is almost here." So lots of optimism. But not everybody was as optimistic, right? So Alexander Fleming was a really smart man and realized that he saw resistance occurring early on. So he was quoted saying in the New York Times, "The greatest possibility of evil is the use of too small doses so that the microbes are educated to resist penicillin, which can be passed to other individuals until they reach someone who gets a septicemia penicillin cannot save," right? So he already knew this before it was happening. And then as early as in the 1960s, things like the R factors were reported, the plasmids now that we know of. So people knew. Look, in 1950s, the use of prophylactic antibiotics really shouldn't be done. So interesting stuff. So it only took 4 years, mass production and use of penicillin to start reporting resistance. But again, we had so many new drugs that were coming out, people were not that concerned, right? So we got resistant, we had a new drug for it. And then after the end of the 1960s, like I said, no new classes were being made. So what we're doing is just slightly tweaking the antibiotics that we had. So like, your first fluoroquinolones, right? So we then made them less toxic and broader spectrum of activity, but not a novel class of drugs. It wasn't until the late 1990s, so 1999, that we got a new class of antibiotics, right? And linezolid was that. So 30 years in production. We're not very quick here with producing new classes. All right, so just talking a little bit about where we are today and in terms of resistance, and then we'll talk about in terms of development. Do you know what this is a picture of? This is kind of frightening. So this is actually isolated from a patient, and this is in Asia. This is vancomycin-dependent enterococcus. So it's not that it's resistant to the drug, it uses the drug, so that would be vancomycin, as food to grow. And this is actually isolated from a real patient. So this is kind of scary. So just to touch on some things they probably hear, MRSA, CRE, MBL, all these things, and this is just really the tip of the iceberg. The amount of the different beta-lactamases that are out there, and all the different, and the efflux pumps. It's just a lot of issues. I think the cephalosporin-resistant gonorrhea is a little frightening, just to think about. So in 2013, CDC put out basically a consensus statement naming things as, or our current issues in ID as urgent threats, serious threats, and the third one is like possible threats or likely threats. So look at where our carbapenem-resistant Enterobacteriaceae, it's right in the urgent threats, and so is the Neisseria gonorrhea and C. diff. And then concerning threats would be things like, vancomycin-resistant Staph aureus. I mean, I don't think we've seen much of it. There may be some isolates reported, but it's still not a common issue. All right. I think this is still an accurate trend. I know this is from 2005, so 10 years has passed now, but most institutions could probably report the same results, that you have more MRSA, more VRE, and more fluoroquinolone-resistant Pseudomonas. So we're really doing well with resistance. I mean, we are right on the rise. So just looking at Klebsiella pneumonia, both resistant to carbapenems and to third-generation cephalosporins. So in terms of carbapenems, we knew that this issue, at least in the early 2000s, was more or less endemic, right? So you think of the Northeast, New York, New Jersey, as having KPC-type organisms. But look at it from 2006 to 2010 data on the right. I mean, might not have as many isolates, but I think pretty much every state in the U.S. now has reported a KPC-type organism. And same trends are for the third-generation cephalosporins as well. I mean, so clearly it's a problem all over the U.S. Now, this was kind of interesting. This looked at isolates reported for metallo-beta-lactamases, right? And you could see that almost every country in the world has reported at least one isolate. And then in India, 1 million people are estimated to either be carriers of this organism or to be infected with it. So the next question, I guess, is why, right? Well, it's multifactorial as to why we're seeing this problem, right? About 70 to 80% of all antibiotics that are used in the US are used in animal feed, right? And this is not to cure or treat any kind of infections. This is just to promote growth, right? So because it's been shown any antibiotic, it doesn't matter which one, once added to animal feed, they required less food to grow faster. So this would be, and it's a not the whole thing is not regulated, right? There's no regulation on it at all. Of course, overuse, we think there's nothing wrong. If we don't know what it is, we'll just give you some antibiotics just in case, because they're kind of benign, right? And this is in the hospital. It's been reported that about 50% of all antimicrobials are prescribed inappropriately or unnecessarily. But it's not just a problem on the inpatient side. The outpatient is a problem as well. And I think the biggest issue is the use of antibiotics for viral infections. It's always easier, or I guess it makes people feel better that they came to their doctor, they got something, they're going to take it. And I mean, there's a great program out there by the CDC. It's called SMART, and it tries to teach just patients as well as providers about the importance of using antibiotics only in bacterial infections, and the fact that symptoms can linger for some time, and that you don't have to feel better in 2 days, and they could still be viral. So I thought this was well represented. So this I just learned about as well. Now the CDC is basically tracking the antimicrobial prescribing patterns of everyone in the US. So there's 3 levels, level 1, 2, and 3. Actually, Florida, not the worst. We're level 2 in prescribing, right? So, which is, I don't know what's going on in those particular states like Kentucky, or like I don't know why they would have a higher, prescribing rate than some of the other places. So
yeah, I think I practiced in Alabama for many years, and I can say that it's a combination of expectations of the patient and also the doctors wanting to just give patients out quickly. So everybody, it's like the one answer starts with an A. So it's not good.
Yeah.
And
So
just to say, here I am. I'm in a better state. So.
There you go. So, in terms of where are we in terms of antimicrobial development? So we got the resistance part down, okay, or we're spreading that. Have you heard of the bad bug need drugs 10 by 20? Right. This is the Infectious Disease Society of America. This is their campaign to get 10 new antibiotics out by the year 2020. Right. Just a little bit about how we think and how we develop antibiotics. So our focus in the beginning was all about, okay, these intrinsically resistant gram-negatives like Pseudomonas, right? Let's get antibiotics out for those. But what is the bacteria doing? They're like, well, you do your gram-negative stuff, and we're the gram-positives are going to start mutating. So you have your MRSAs, VREs that are coming through. So then you're, oh my God, I need to start doing something for those. So in the 80s and 90s, we're starting to develop all these drugs for, your gram-positives, but then it's your gram-negatives that are now, getting these really broad mutations and getting really bad mechanisms of resistance. So just, we're always kind of one step behind them. We're chasing them. We're not proactively doing things. And you can even see this with the gram-positives. I mean, with recently the drugs that came out, most all of them are gram-positive drugs. This is like a familiar graph for all of us, but just something to keep in mind. We're not getting new drugs out there quickly. And this is the antimicrobial pipeline data. The most updated was December of 2014. So currently there's 37 antibiotics in development. 10 of them are in phase 1. 18 are in phase 2. You have 8 that are in phase 3, and then 1 that got a new drug application approved. And just historically, about 60% of all drugs that make it into phase 3 actually get approved. So just to keep in mind, not that many in phase 3 right now. Interesting enough, 24 were designated as qualified infectious disease products, or QIDPs. And basically what this means, you get a special designation that now you're able to extend your patent from the FDA. So basically it's an incentive for drug companies to make the drugs, because they can actually then profit further from it, because nobody can make any generics. So as I said, only 1 of the drugs actually got or has a new novel type of mechanism, where everything else are just old drugs that are tweaked to try to overcome resistance somehow. I just put these abbreviations up here because we're going to look at some of the drugs, and so just so we can always refer to this if needed. Alright, so I'm only going to discuss basically the phase 3 drugs, just because the phase 2, very few phase 2 and phase 1 eventually come to market. So fusidic acid, I remember reading a supplement in CID on this maybe 3 years back. So excited, looked so great, right? It's a gram-positive drug. It has no gram-negative activity. So I was so excited when it was, they were talking about it, and it still hasn't come to the market. And now there's plenty of resistance that's been reported. So if you PubMed it, that's the first things that pop up, are like resistance isolate of fusidic acid. And so then you have a new there's 2 C. diff drugs up there that are pending. You have a new macrolide or macrolide type of drug. So plasmamycin is a new aminoglycoside. Let's see, there's the only thing I could find for the new tetracycline type of drug, nothing, not for that one. No, for the new fluoroquinolone, there's like a phase 2 that you can read about. They compared the drug to Tygocil, and it seemed non-inferior. It's only IV, so we'll see where that goes. Not too much out there. But what I'm really excited about is actually the Carbavance, or the meropenem, with a new beta-lactamase inhibitor that is coming to the market, and they're actually starting to recruit phase 3 trials, and it's called Tango 1 and Tango 2 trial. So a Tango 1 trial, it's looking to get about 800 people into the trial to compare this new drug with Zosyn for complicated urinary tract infections and pyelonephritis. So it would be interesting to see, and it's going to be a non-inferiority trial. And then a Tango 2 trial, which is something new, and we haven't seen this before. It's actually looking to recruit about 100 patients, and what they're calling it, it's going to be a multi-center randomized open-label study of Carbavance versus best available therapy. So basically, you're going to recruit patients with severe infections, so like VAP or bacteremia, with multi-drug resistant organisms, and you will compare this new drug to whatever is the current best of practice is, because we don't have good drugs for it. So that's why you see some of the potential indications are specifically for CREs. So they're looking at organism-specific indications and not disease-specific indications. So kind of exciting. So they started recruiting. So we'll see. All right. So that's great on paper. So what does that all mean clinically to us? There are real people who actually have these isolates. So, this you can find all these testimonials on the IDSA website. This is Carlos. He died 2 weeks before his 13th birthday from community-acquired MRSA pneumonia. This was very frightening, that it's predicted that superbugs, will kill more than cancer by 2050. It is estimated that if we continue at the rate we're currently going at, additional 10 million people will die because of multi-drug resistant organisms. Currently, the death rate is 700,000. And it's not just people who see the healthcare system, it's out in the community. This was a 20-year-old Brazilian model who died from multi-drug resistant pseudomonal sepsis from a UTI. So it was very, very sad. they had reported, they amputated her legs, her arms, tried to save her, and she ultimately expired. So, ironic, this is Josh. He survived a skydiving accident when his parachute wouldn't open, to ultimately die in a hospital from a multi-drug resistant Enterobacter infection. So Moffitt is not by any means, being protected or living in a bubble or an island. These patients are also starting to see more and more multi-drug resistant infections. This is a blood culture, an Enterobacter on a patient. Again, this is a body fluid culture. Whether you need to treat these things or not, but the point is, once you're colonized with these things, you're more likely to then become infected with multi-drug resistant. And then that's, another blood culture in a patient with a KPC. I mean, there's just nothing to really treat this patient with at this point. So, just to talk a little bit about what's been recently approved in terms of gram-positive drugs and gram-negative drugs, and feel free to tell me what you know about them, because again, I have no clinical experience with these drugs. They're pretty new, so I can just tell you what's kind of out there. I shouldn't ask Elias about this. So Dalbavancin was approved in May of 2014. It's a semi-synthetic lipoglycopeptide. Kind of has a similar mechanism of action that we currently see. What's unique about this drug is its half-life. If you look at its half-life, it's 346 hours. So there's a long half-life. All right, so FDA approved indication, right? And you will see this trend over and over again. It is approved for acute bacterial skin and skin structure infections. So I'm assuming it's the easiest indication to get up front and then do further studies. But just keep in mind that all the gram-positive drugs we'll be talking about only have this indication. And the dose is you get a gram, and then in a week you get another 500 milligrams, and you're done. And then, of course, it's renally adjusted. If you're interested, this is how it looks compared to vancomycin. So also a big molecule, right? Just like vanc. So some clinical and in vitro data that we have, both MRSA and MSSA, right? Your strep. For Enterococcus, remember, there is only in vitro data. So, and it's only for VSE, right? It would not make sense for this to have activity against vancomycin-resistant organisms, since it's a vancomycin type of drug. All right, so the studies, you had your Discover 1 and Discover 2 trials, and they were the same, or design was very similar, so I kind of lumped them together. Randomized double-blind, double-dummy, non-inferiority trials, comparing Dalbavancin to vancomycin, right? Patients were allowed to convert to an oral agent like linezolid after 3 days of treatment with IV. And the primary outcome was this early response. You'll see this in a lot of these trials now. They're looking at early response of 48 to 72 hours. Basically, you're not requiring additional antibiotics. It's not spreading. You're afebrile. For your skin infection. And if you look, Dalbavancin was basically non-inferior to the vancolinezolid group. All right, some of the caveats with this drug may be cross-reactivity with other, with things like vancomycin. It's not known, it hasn't been studied, so just be careful. Still concerned for red man syndrome, so you want to slow down the infusion if the patient does develop it. And interestingly enough, in the trials, it was found that more patients in the Dalbavancin group experience LFT elevations 3 times above the upper limit of normal. The overall LFT abnormalities were the same amount, but the more of the severe ones occurred in the Dalbavancin group. And then, if you're curious, the cost. Anyone want to take a guess?
Is it $2,000?
So the 500 milligram vial is about $1,800. So for the total course, it will cost about $5,300.
Holy smokes. Wow.
So just putting it out there.
Some serious bread.
So the next drug is your Oritavancin. It was approved in August of 2014. Again, it's a semi-synthetic lipoglycopeptide, and what's unique about this drug is basically it is quoted to say to have 3 mechanisms of action, right? So you have your top 2 where you have the inhibits the cell wall synthesis and 2 mechanisms, but plus it also disrupts the bacterial membrane integrity, right, and causing like cell lysis. There's another drug with a half-life that's really long. Its half-life is 245 hours, and the dose for the same indication as we previously discussed is a single dose. It's 1.2 grams over 3 hours. Interestingly enough, it does not need to be renally adjusted. I'm just concerned what happens if your patient develops an allergic reaction to this drug. Then what do? I mean, that's a really long half-life. And then again, comparing to vancomycin and Oritavancin, see, it's just the side chain that's different. So again, our clinical data is in your MRSA, MSSA, your strep, no VRE activity, of course, and so some VSC data, not so much anything else. Oritavancin was looked at in the SOLO-1 and SOLO-2 trials, and again, it's a randomized double-blind non-inferiority trial, very similar with Dalbavancin, except that there was no switching from vanc to anything oral. Again, same type of primary outcomes, 48 to 72 hours, and again, non-inferior to vancomycin. Apparently there's bacteremia trials going on with this, so when that happens, I think it'd be a little more exciting. Just 'cause right now, who needs a skin soft tissue, for 28 days? I don't know. We'll see. All right, this I found really interesting with this drug. So your patients who are an anticoag, you might have some problems with this. So it gives a false elevation of your PTT as well as INR. So if you have patients on a heparin drip, you may see a bump. It's not a real, it's a artificial type of bump, right? It interferes with the lab assay. And the same thing for the INR with warfarin for the first 24 hours. So be careful of that. There's interestingly some CYP drug interactions because it is a weak inducer and an inhibitor of certain substrates, so something to be aware of. In terms of monitor for osteomyelitis, what was noted is that when in the Oritavancin group, more patients went on to develop osteomyelitis than patients in the vancomycin group. So if you that's where that comes from. Why? I don't know why. And then the cost for this drug is about $3,500. All right. So Tedizolid was approved in June of 2014, and again works kind of like linezolid, right? Same. It's like a second generation. What's interesting, it only has an FDA approval for up to 6 days, right? Again, for skin and soft tissue infection. So it's a single once a day instead of twice a day drug. I mean, looks like linezolid, right? Right? And I'm gonna skip over again some of the in vitro and then, but again, it's a gram-positive drug predominantly. And then if this was they had an established 1 and then an established 2 trial, their design was a little bit different, but compared to Tedizolid versus linezolid, and found no difference between the two groups. And then the established 2, what was slightly different was that they looked at size reduction, right? So that's how they defined their outcomes. And again, no difference between the two groups. So none of these studies are superiority trials, right? They're all like non-inferiority trials. So then you would ask, so why would I use this drug over linezolid, right? So the claim is that it does not have any thrombocytopenia that develops, right? No anemia, no hematologic issues. But yeah, the drug was only studied for 6 days, right? With linezolid in 6 days, we also don't tend to see these things. So in a phase 1 trial that went on for 21 days in healthy volunteers, there was a trend towards duration and dose dependent, hematologic issues. It seems not to have any serotonergic activity like linezolid does, but really cannot be assessed because those patients were excluded from the trial. Anyone who's on an SSRI, because if they would have gotten linezolid, it's a black, it has a very strong statement. So yes, in theory, it does not have any activity. No, we don't know because there's no clinical data with it. Can't really use it at Moffitt because it has no data, or it's not recommended specifically in the package insert. Anyone with an ANC less than 1,000, so anyone at Moffitt, and basically no data on VRE. So we'll see where that goes. But
who's the pharmaceutical company?
Hold on. Cubist. All right. Now, more fun stuff. I was so excited about these gram-negative drugs coming out, and then I wasn't so excited. Okay. Isn't that a pretty picture? All right. So the first one that came out was in December 19th of 2014, and it's Ceftolozane-tazobactam, or Zerbexa. So we kind of know what the tazobactam is, right? So it's all about the cephalosporin, right? It works like any other cephalosporin does, penicillin binding protein, and inhibits wall synthesis. But what's interesting about this drug, it basically retains activity against Pseudomonas. There's multi-drug resistant, including that is of fluoroquinolone resistant, and as well as some of the aminoglycoside resistant. Just remember, this drug is no better, right, than third generation cephalosporins for Enterobacteriaceae. So this is an anti-pseudomonal drug, not because the tazobactam is already a beta-lactamase inhibitor that we have and we use. So whatever it's going to inhibit, it's going to be no better than Piptazo against your, ESBLs, for example, right? So this is an anti-pseudomonal drug. No anaerobic coverage, and none of these two drugs that I'm going to talk about, even though we associate Zosyn, right, with, having anaerobic coverage, but that's because you got the PIP there, right? And then the beta-lactamase inhibitor helps with the beta-lactamase producing organisms that would normally be covered by PIP that are not, if they weren't beta-lactamase producing. All right. So if you had to compare this cephalosporin to anything, it's kind of like ceftazidime, right? So again, this is where its chemical structure is. So the current FDA indications, right, is for treatment of complicated intra-abdominal infections in combination with Flagyl, right, as well as treatment of complicated urinary tract infections, including pyelo. What I'm gonna point out here actually is focusing more on gram-positive. It has limited gram-positive activity and no Staph aureus activity, right? So no activity against staph. All right. Skip this. All right. So this was just published in CID. So this month's CID. And it's called the Aspect trial, right? And it basically used two randomized multinational double-blind studies and compared Zerbexa to meropenem for complicated intra-abdominal infections. And then the primary outcome was basically clinical response at the test of cure. And basically there was no difference between the two groups. Okay, there was some actual numerical difference that you could see more in the phase 2 trials, more than in this one, but again, it's non-inferior to meropenem. can't tell you much about the UTI study because it's actually not published. So any data about with a phase 3 UTI trial or that you can get is actually only from the package insert. One head-to-head with Levaquin, which I thought was kind of interesting, and note the dose, which I also thought was kind of interesting, and continued with IV for the whole entire duration. But and then the primary outcome was complete resolution or marked improvement of the symptoms. There's some claim that it's superior to Levaquin. But when you took out the groups that started off with the quinolone-resistant isolate, right? So you can't compare, resistant to one drug and susceptible to a drug, see which group does better. If you looked specifically at those that did not start out with the quinolone-resistant organisms, the two drugs were exactly the same. All right, just some caveats about this drug. I can't tell you much about the UTI trial, again, because it is still not available. It's supposedly getting published soon. There was interesting enough, both in phase 2 and in phase 3 trials, there was increased mortality noted in patients in the Zerbexa group versus the meropenem group. Couldn't attribute it directly to what. And then also there's decreased efficacy was noted in patients with decreased creatinine clearance. So something to keep in mind, and I don't know what the reason for that is actually. And then there's an ongoing VAP trial right now. It's basically, there's one that was comparing the drug to Pip/Tazo, but that trial is no longer recruiting according to the clinicaltrials.gov. But it still hasn't been published, not that I've heard anything about. But there's another one that's being recruited actively, and that's to compare against meropenem. Just note the dose, so it's going to be double the dose that is currently approved. So, and then if you're interested, the cost per day for the drug, for the current indications, about $300 a day. For the VAP indication, $600 a day.
Amanda, you looked up that Zerbaxa for us, right?
No, that was IDPodcasts.
That was IDPodcasts. Okay, that was quite a bit more expensive. So just to clarify, so the tazobactam doesn't enhance the Pseudomonas activity, just of the enteric bacteria. So it's really the ceftolozane that you're relying on for Pseudomonas coverage.
Yes. And then just something else is, in order to get susceptibilities to this, you would have to either, the drug company does offer a lab that you could send this out to get susceptibilities, or they can give you e-tests. But again, the caveat there is they're not to be used to make clinical decisions type of thing. So, and I think CLSI has established, breakpoints for this drug. You can find them in the package insert. I want to say it's maybe less than 2 for Enterobacter ACA and less than 4 for Pseudomonas, but I may be wrong. So
is that drug is not available at Moffitt or won't be in the near future?
No. Nope.
Okay, gotcha.
And you were able to get pricing for this drug because
Right now, yeah, it's on like the open market. It's like $2,400, $2,800 a vial.
Yeah, I mean, that's great. So Ceftazidime, I'm speechless. That takes a lot. So Ceftazidime-avibactam. So it was approved in February, and it is, what's unique about this drug basically is the beta-lactamase inhibitor itself, right? Because we already have ceftazidime. So it is a first non-beta-lactam, beta-lactamase inhibitor. And it has activity against many beta-lactamases, including class A, C, D. What's missing there? Yeah, and what's B? Yeah. So it is not active against your metallo-beta-lactamases. And note how it says some amber class D. What's in class D for the most part? KPCs, right? So your broad, beta-lactamases would go into usually your class D, A and D. So, but A more ESBLs. So this this drug you think of as an enterobacteriaceae drug, right? So the avibactam is what gives you additional activity. There's no additional benefit for your non-fermenters. So like things like Acinetobacter or things like Pseudomonas will be the same as ceftazidime, okay? So I guess depending on what your problem organism is, you could benefit from one of the drugs, but they all have gaps in them, right? There's no like great all around. Again, no better than Ceftaz for your some things like Haemophilus, right? So if you're interested, so you have your sulfa-antibiotic, your clav, and then avibactam is right up there. So it's a whole unique structure. Okay. Again, its indication is the same as that for Zerbexa, and again for complicated intra-abdominal infections with flagell, and treatment for complicated UTI and pyelo. Again, I'm going to skip over this. This is a gram-negative drug, limited gram-positive activity or anaerobic activity, right? So that's why I got to add the flagell. Correct me if I'm wrong, but there are currently no phase 3 trials that are published for this drug that I can find. But there's a phase 2 that was published in Journal of Antimicrobial Chemotherapy. That was interesting. It was a phase 2 randomized double-blind active control trial that looked at Ceftaz-avi versus meropenem, but I do want to read some of the exclusion criteria, because this drug would be, for your sickest of the sick patients that you would want to use, as well as, the whole term of complicated. So I thought this was really interesting. So patients were excluded if they had any of the following: abdominal wall abscess, small bowel obstruction, ischemic bowel without perforation, received other antibiotics within 72 hours, concurrent infection that may interfere with evaluation of the study drug, anyone with an Apache score greater than 25, anyone who had LFT abnormalities 3 times the upper limit of normal, anyone who had a creatinine clearance less than 50, immunosuppressed, CD4 count less than 200, anyone who had a BMI more than 45. Hello. These are like all the sick patients, so they excluded anyone who had thrombocytopenia, anyone who had absolute neutrophil count less than 1,500. So, a lot of exclusion criteria. So just keep that in mind, that if you're going to extrapolate this to your really, really sick, it may not be as good as meropenem. I don't know. It may be, once the phase 3 trials come out, maybe it'll be a little easier to say. And again, look, it was no different than meropenem. And then there's a phase 2 UTI trial that you can find also. Note the dose that was studied it's a much different dose than we're using, and it was compared to imipenem and basically looked at efficacy, and they only evaluated the 62 patients, for the primary outcome, and it was non-inferior to imipenem. Very limited data to report on. But this was actually noted early on that patients who had a creatinine clearance between 30 and 50 had an increased mortality. Or just worse, had worse outcomes, right? So in this intra-abdominal trial, so they had the cure rates were much lower than that of meropenem, and it was thought to be because it was underdosed in that patient population. And since then, the package insert has increased the dosing recommendation for this particular patient population by 50%. So that's what the thought behind it is. But that's a significant difference between the two groups. And again, increased mortality in some of the other trials. Specifically, if you did the subgroup analysis, again, probably related to the underdosing. And of course, the package insert itself basically states that we don't have a lot of data, so just make this last resort. And I think that's a very appropriate indication for this drug, is if you have no other options. Again, with susceptibility data, I don't think you can even send it out to a lab to get susceptibility data. It's going to be a tough one. And then I'm just gonna kind of skip over this, but there's a whole document that's put out by World Health Organization, the CDC, kind of talking about that. Look, we're approaching this post-antibiotic era, and what you can do as providers, right? And it basically talks about slow the emergence and prevent spread of resistant bacterial. Talking about that we need to educate people, we need to get some oversight over a vet, friends, as well as just promoting stewardship in animals, right, and out in the community. The One Health surveillance effort basically refers to, it's not animals are here and humans are here, we're all getting touched by this problem, so kind of getting the collaborative effort together. Rapid diagnostics is another thing that is really a big push, right? Why do we use broad spectrums? Because sometimes it just takes too long to get the diagnosis or to get the susceptibilities. So if we can get our answers faster, I think we can get our patients off broad spectrum antibiotics faster, or get the right drug for the bug faster to them. So that's a big push right now. Again, there's a push to, let's not be drug companies here and then academic researchers here. If we all shared our data, we can get drugs out faster to the patients, right? So that's another thing that they're encouraging. Again, collaboration, partnership. All right, and that's our president is very aware of this problem and has budgeted quite a large amount of money for 2016 to deal with this issue. So this is something that's finally out in the public eye. So hopefully we'll get more drugs faster. So this is kind of just to summarize. Again, there's not a lot of new drugs that are being developed, and we get resistance faster than you can imagine, right? Even for the new 2-gram negative drugs, if you put in the Ceftaz-avibactam, right, into PubMed, the first 2 articles that pop up are resistance articles about isolates. So just be on the lookout. Things come out, the resistance comes out faster than the drugs themselves. So and I will take any questions you may have.